you will find as we move through this that I explain this in a sequential order because here's my premise. I've been teaching this for so long and working with suicidal clients. What I have come to discover and know to be true is that and I wanted to mention, I've worked at a university, I've worked at a children's center, I've worked with chronically mentally ill patients, I've worked with partial hospital, I've worked with intensive outpatient, I've done addictions. So I have not done it all. I've worked at a national treatment center for eating disorders. So I've done a lot of work in different venues. And as some of you might know, people that have eating disorders have a very high ratio for having suicidal thinking. And some literature would suggest that more than 50% of people that have an eating disorder die from suicide, not from the medical complications. That's pretty serious. That's something that practitioners need to know, because in their assessment, not only are you having to assess for suicide and for homicide, but wouldn't it be good to know then to ask about disordered eating if we know that there's a high correlation? So it's information like that I hope to share with you. So I've worked in many different venues, and what I've learned when I was teaching graduate students especially is I can jump into teaching you assessment measures, which is usually what practitioners, want. Teach me how to assess it. That's not my strength area. But before I can teach you how to assess, before I can teach you what interventions that you would use after you do an efficacious assessment, and before I can teach you how to do good postvention based on your understanding of interventions and assessment, I really need to slow this down. And this is the part, another gap area, I think, is to help practitioners understand this morning, and so we're going to talk about it for about 40 minutes. What is your value system related to suicide? What have you learned about suicide? Because you cannot convince me that in not exploring this on your own, not discussing this, truly reflecting on what your experience is, doesn't impact how you ask a question, if you ask a question, when you ask the question, and what you do with the information. Okay? And the best example that I give is, then I can say this, I hope, with respect, that I live right now in Alabama. And if there's anyone here from the South, if you're born and raised to believe that if a person dies by suicide, that they will burn in hell, and that is your value structure, it absolutely impacts how you tend to the survivor, how you tend to the parent whose 15-year-old daughter has just attempted suicide. And so while it sounds good in theory, I think, for us to go through our training, in graduate school training or doctoral training, and be taught we are objective and we will separate our feelings from our, training, I think that's a bunk. Because as human beings, what we should be taught is that and many programs, again, emphasize, you will feel this stuff. And you need to be aware of it and know what to do with it. And so I think in graduate schools we're taught that to some degree, but when it comes to suicide, and this is a rhetorical question, how many of you first even had training in a graduate level on working specifically with suicidal clients? And if you did, how many of you had training on if you lose a client to suicide, what to do? Or how many of you in that training had any exploration of what do I think about people who die by suicide? Because if you didn't, and this is your first time doing it, hopefully it won't be your last, okay? So what we know to be true is that consistently still today, few counselor education, psychology, or psychiatry programs tend to deal with suicidal clients. Consistently, over years of research, no other patient behavior generates more anxiety than working with a suicidal client. Well, that's staggering to me. If we know that to be true, that no other patient diagnosis or behavior generates more anxiety in a psychiatrist or in a nurse, why would we not help them learn how to work with it? And if it's true that on an average, and I think that we're making improvement, the average mental health practitioner or professional gets less than 2 hours of training in working with a suicidal client, And again, I think that we're making some progress in graduate programs, but if that's the truth, that's the equivalent of me needing brain surgery, right? And choosing a surgeon who's had less than 2 hours of training fixing the brain. Not going to be my choice. Right? Okay, so you can see in the course of today, you will have had more training than someone coming out potentially from another program. Okay, that's a bit daunting to me. What about you? I find that a little bit concerning. That's where my sense of advocacy comes in. So we also know, let me go back, we also know that there's an upward trend in malpractice suits, and so back before the deinstitutionalization is where I track it. Back before the deinstitutionalization of psychiatric problems, practitioners could refer, very, very easily to an inpatient unit. And if they weren't well trained and didn't understand their own anxiety and working with that client base, they could send them somewhere. But that's not the case anymore and hasn't been for quite some time. So as practitioners, we have to learn, and you already know this, how to work with potentially highly suicidal clients.